Our next keynote speaker is Dr. Kristopher Rallah-Baker, and he's the current president of the Australian Indigenous Doctors Association. And just a note to those who are watching it via live stream that this will not be live streamed. Dr. Chris is a Yagara and Birrigubbi man from Queensland and is the current president of the Australian Indigenous Doctors Association. As Australia's first Indigenous ophthalmologist, he currently works as a consultant locum ophthalmologist across Australia. He's worked closely with Indigenous communities to provide ophthalmologic care and that they may not otherwise have received. He sits on both the Royal Australian and New Zealand College of Ophthalmologists Selection Board and Indigenous Communities, and is heavily involved with the Fred Hollows Foundation nationally. Dr. Chris' registered training was undertaken in Queensland, and he subsequently was awarded the Fred Hollows Foundation Fellowship, where he worked in Alice Springs and the Pacific Eye Institute in Fiji. Dr. Chris has published in the area of neuro-ophthalmology and refractive surgery. But on a personal note, he's actually an accomplished piano player. Is that right, Dr. Chris? So that's really great. An artist and a cabinet maker. So he has a very wide variety of skills. Can you please welcome Dr. Chris?
Wallaby is hello and welcome in the words of my mother's tongue, the Yagara tongue, which has been spoken on the country in which we speak for obviously millennia. And I welcome everybody to country today. We meet at an important site in Yagara country, being a hill, but a hill from which a stream once ran and probably still runs through pipes laid under the ground, and just down at the park there at Roma Street Parklands, where there's now an artificial lagoon, was a significant natural lagoon when the Europeans arrived, and it was an important meeting point. And in that context, it's ironic that we meet just above that today as a group of Indigenous intellectuals, as well as non-Indigenous intellectuals, to discuss some really quite important issues. We had a crossing point just down at Gurulpa as well, which is near here, and it was a major thoroughfare. But I thank Chelsea Bond and the organising committee for inviting me here today. It's a great privilege to be here, and there are many giants in Indigenous health who I've looked up to for a long, long time in this room. And it's very humbling to be alongside them and speak alongside them. So the topic for today is moving beyond the front line, and I'll be speaking with a couple of hats on. One is with my AIDA President's hat on, and I want to go through some of the work and journey that AIDA has undertaken. And then I want to talk about my own journey through medicine and ophthalmology and how that young black kid from Holland Park made it up onto the stage today, and what a journey it's been. So many people in the room will know my mum, Rallah-Baker, and she's worked tirelessly for a long, long time. She was a health worker way back in the 1970s, and she was an enormous influence on my career and the progression of my career. And so, as I said, I grew up in Holland Park and Brisbane, and at the age of 17 decided quite boldly that I wanted to do medicine. Again, with the encouragement of Mum and Dr. Noel Heyman, who actually came over to our little weatherboard house in Holland Park and sat down with me and spoke about medicine and his own journey into medicine. And, you know, I reflect back and I think, wow, what a ballsy young kid. But at the age of 17, I figured, well, yeah, I can do this, and so let's apply for the program. So I applied to New South Wales, at the University of New South Wales and the University of Newcastle. I better time myself here. And I was actually offered a position at both universities under my own steam. So I considered my options, and one of the issues I want to talk about today is cultural safety and the work that AIDA is doing in that space. And quite unconsciously at that point, I actually chose the most culturally safe pathway for me to get through medicine, and that was at the University of Newcastle at the time. And there was an incredible woman, Professor Gail Garvey, my on-campus auntie, who was the director of the unit down there. And when I say unit, it wasn't any big flash building or anything. We had an old locker room downstairs in the medical sciences building. But it was our space, and it was an important space. And my brother over here, Neil Wilmot, was there with me in those very early days. And it was a space where we could retreat from the outside world and be ourselves. And there were a whole bunch of Murrays back down there back then too. When I say a whole bunch, like 10, because there weren't that many of us. But it's because Newcastle was an undergraduate program and it had this safe space. A number of years later, James Cook Uni opened up, and we had a whole lot of Queenslanders went north. But at that point, it was Newcastle. And that was back in 1997. And in April of that year, Gail Garvey, and under her leadership, it was decided that we only had about 10 graduates at that point, and I think 20 medical students, and about 15 of us are at Newcastle. It was decided that we should all sit down at a conference just north of Newcastle in Salamander Bay. And it was called the inaugural Indigenous Graduate and Undergraduate Doctors Conference. And so we all arrived. There were about 50 people there, and we had Puggy Hunter from Nacho was there, and we had representatives from Te Ora in New Zealand, and Native Hawaiian physicians and Native American physicians. And there we were as this bunch of young blackfellas thinking, oh, what are we going to do? In awe of these international organisations who had been around for so long, and yet we had graduated our first doctor, Dr. Helen Milroy, in 1983, only 14 years before. I remember thinking as an 18-year-old, just how overwhelming this was, but how exciting this was, and this whole space was so exciting. And of course, we'd just come out of the Keating era as well, and how it had just seized control of the nation. But there was still this buzz around, Indigenous health, and the Redfern statement was still very fresh, and Mabo was still spoken about. So it was this incredible period. And we all went up to Salamander Bay and sat down. And at the end of the meeting, it was a couple of days, we decided that we would form an organisation primarily to support each other, to help each other through, because this was an important thing to do. And we kind of knew why it was important, but we didn't have the whole context because what we were doing was brand new in this country. So we formed AIDA, the Australian Indigenous Doctors Association. And 21 years later, it's a deep, deep privilege to be the president of that organisation. And I'll talk us through how far we've come as an organisation. But that was back in 97. I then progressed through medical school and completed my medical degree in 2002 and came back home here to South East Queensland. And I've had an interesting journey to get to ophthalmology, to become a consultant ophthalmologist. I didn't follow the classic pathway, as a lot of us, our graduates, don't. I worked a couple of years in the mainstream system, and it was an incredibly violent system, culturally violent system, and I left. At that point, I vowed never to come back to medicine, and I worked down in Logan Boat as a health service district, and I led the Indigenous health team down there. And it was this rebuilding period for me, where I was able to rebuild myself and recognise the importance of what I'd achieved in a medical degree to then return back. So I worked down there, I grew the unit, I came back into medicine, and then I progressed through the ophthalmology training program. And succeeded despite the program, not because of the program. And they're important words, because of the issue of cultural safety and the lack of cultural safety in a lot of, not only the universities have improved significantly, but the colleges themselves. And some are progressing much more quickly and effectively than others, but there are a group of recalcitrant colleges that are particularly slow, and that's why I've asked for my session today not to be streamed. Because even standing here as the President of the Australian Indigenous Doctors Association and a fully qualified consultant ophthalmologist, I am under threat. As astonishing as that statement is, it's the absolute truth. So I've asked for it not to be streamed for those reasons. But I want to talk a little bit about AIDA and the work that AIDA does. Members of our fantastic secretariat are here today, and I'd like to acknowledge them, and our current CEO, Anita Mills. But we work across a number of areas, and as I mentioned before, it's not only with the universities, it's also with the colleges. And I want to take you through a journey of our active work at the moment and how that fits into the theme of today of moving beyond the front line, because it's really what this is. It's about moving forwards and about progressing the issues that Cindy spoke about. So AIDA's work in the university sector is we work very, very closely to develop the membership and promote the idea amongst our young kids that yes, a career in medicine is definitely possible and that they should get on board with that. And at our recent conference in Perth, I was having a conversation with one of our second year students. It was just, like so many of our stories, this remarkable story, someone who'd grown up outside of a capital city and until year 10 actually couldn't read. He couldn't read anything, and he self-taught to read and then succeeded through years 11 and 12, and now he's on the medical program. And we have so many of these stories coming through. So AIDA works very, very hard to engage these students and engage these kids who have the intellectual capacity to succeed in their studies, but not necessarily have been given the right to believe that they can study at university. So that's a big area of work. AIDA also acknowledges that engaging students very early in their degree and supporting them through that degree, just like the University of Newcastle did with me, is a very effective way of getting people through, because it's one thing to engage students and have students recruited to the programs. It's a very separate issue to then retain them and have them finish at the other end. And it's finishing at the other end that's the really important part, because that's what grows the workforce. And these sound like such obvious concepts, but for a lot of people in the mainstream system, they need to be taken along a journey to understand that. We work closely with the Australian Medical Students Association. We're about to renew our Memorandum of Understanding with them. And we have a very, very active student representative body that works in that space. And we also work very closely with the medical deans of Australia and New Zealand and the Lyme Network, Leaders in Indigenous Medical Education. And we're in fact in the process of renewing and updating our agreement with the medical deans, and an important piece of work. We embed ourselves in a lot of organisations, and you know, you talk to the early founders of AIDA, and they have these remarkable, incredible, and often very funny stories about how they would stack meetings to get AIDA into certain positions. And Lewis Peachy, people in this room may know him, he's a wonderful speaker, and he talks about this process. So we continue to try and stack meetings as far as we can, but our vice president, and I'm not suggesting that we are stacking any meetings inappropriately, but our Vice President, Associate Professor Shannon Springer is a member of the Lyme Reference Group, and in that context we are very involved with a lot of the other peak bodies working in this area. In terms of our workplace policy, we've released a number of policy papers, but in 2017 we released a paper titled The Aboriginal Torres Strait Islander Medical Student Retention, which drew on data from the medical deans, and it's about these collaborative relationships. And a lot of mainstream organisations are not only engaged in the collaborative efforts, but are learning the Indigenous way of doing things. And that's particularly in the context of the Council of Presidents of Medical Colleges, and in sharing information to embetter not only Indigenous health, but the entire health space. So the medical deans shared data with us, which was fantastic. And it led us to meet with them directly to discuss ways of, again, how to engage and retain our medical students. It also allowed us to pin down some factors in that space with numbers, which up until then had been a little bit difficult to come to. So we developed national data sets, and there were deficiencies to the data sets. So we knew when people weren't progressing through, but we couldn't separate people who were discontinuing their medical education from deferring the education. So there's still work to do in that space and clarify some of that data. And also don't factor in the varying lengths of the degrees. So if it'll state someone's in a degree, but we don't know how far along the path they are and whether they're struggling or not. So there's work to do in that area. But it did give us trends, and the overall trend, and the positive upshot of all of this is that the numbers are growing, and the numbers continue to grow. And on the numbers, we currently have, I think it's around 350 medical students nationwide, and over 450 graduates nationally. And ADA itself have over 500 members, and we had over 470 members at our recent conference this year. And so reflecting back to 1997, when we had just this handful of people in the room, it's been this remarkable journey to watch the organisation grow, but to watch the space grow as well. We now have fellows in a number of the colleges, and all of the colleges at one point now have had a trainee, and most of them have current trainees. So that's an enormous achievement in itself, because there are some, as I said, some very, very conservative colleges who are slowly coming to the party, but who it's been quite challenging to actually engage and have them take some of our trainees on board with them. In terms of numbers, in percents, we need to achieve about 3% of the total medical workforce population, which is around 91,000 registered medical practitioners. We sit at about 0.47% at the moment, which doesn't sound like much, but it's an enormous achievement in 20 years. And we, as I said, we continue to grow those numbers towards a target of around 3,000. Once we get to 3,000, we'll get to population parity. Then what we'll do is we'll start to argue that we need more doctors because we need to match it against health statistics. But the first step is to achieve population parity. And the trajectories are growing, so more and more people are coming into the programs and training as doctors. In terms of our projects, we have a number of projects. So there's the NM10 project, which is the National Medical Training and Advisory Network. It's a Commonwealth network. We sit with the Chief Medical Officer and advise on the whole medical system for the next 15 years. And we also work closely with the Council of Presidents of Medical Colleges. The NM10, the Advisory Network Specialist Trainees in the Medical Workforce Project, is an in-house project that AID is doing, and that's about assessing the numbers of individuals within each of the colleges in the training space, and then working with the colleges to improve the cultural safety and improve the retention and then eventual graduation of those graduates. And CPMC, Council of Presidents of Medical Colleges, is also very, very involved in that process. And I mentioned earlier that a lot of these mainstream organisations are learning from the Indigenous way to do things, and that is to share and advocate and work together. And recently, CPMC, we requested that they all feed in information that aligned with the national standards, excuse me, Indigenous standards that have been set down under the national law. We thought we'd have kickback first and foremost. We thought they were going to say, no, you're not going to have it. But to their credit, all 15 colleges fed back. We were then going to compile that information and create a briefing of gold standards in how to work in this space and how to address the standards. But actually there were elements across all of the colleges that were better than others, and all the colleges working very, very hard in that space. So we thought, well, all of these 15 documents really are gold standards of how to approach this. And the next step was to ask each of the colleges if they would share with each other. And we didn't expect them to share these documents because it had the potential for competition and criticism between the colleges. And they're made up of doctors, they're competitive people. So we thought we'd ask the question, expecting that the answer would be no, but again, to our great surprise and delight, the colleges agreed to share all that information. So these are some of the significant inroads in the policy space and in the space of interacting between the colleges that AIDA is actually engaging in and taking each of these colleges along a path that they haven't been along before. They've been largely siloed. So there's lots and lots of good work going on there, driven, of course, by a very, very strong secretariat. We also have a research project and excuse me, It's called the Strong Futures Project, and that's collaboration between AIDA and medical deans, and Associate Professor Shannon Springer is helping drive that. And we have our representation and strategic engagement as well, engaging with the other peak bodies to work in this area, because it's all about a collaborative effort to improve this space and improve the number of people within the workforce, not only medical graduates. We've a very significant achievement recently is we now sit on the AMA Federal Council, which 20 years ago that would have been absolutely unimaginable. But we now hold a permanent seat on the Federal Council and feed directly into the Federal Council. And we have a number of very significant supporters in that space, and that will be ongoing. Again, due to the very significant efforts of those who have come before me as presidents, but also very significant efforts of AIDA as an organisation and our, a number of past CEOs and very hard-working people. We advise the National Rural Health Commissioner, and we're currently feeding into AHPRA's Aboriginal and Torres Strait Islander Health Strategy Group. So there's lots and lots of work going on. Now, the really important stuff, and the where the tar hits the road is we can have strategies, we can have conversations, we can bring people along to collaborate, but really, as I've suggested already, some of the barriers in getting people through and some of the barriers in moving beyond the front line are to do with the R word. And when I say the R word, I refer to racism. I was at a meeting last week with one of the national colleges, the Royal Colleges, and I was standing there, similar room to this, and I thought, gee, what do I do here? Do I actually drop the R word? And I thought, yeah, I'm going to have an Obama moment here. So I did. I dropped the R word, expecting backlash and expecting pushback, because we live in a country where it's almost taboo to talk about racism. And if we compare and contrast ourselves to other nations, like the USA, they have a much more frank and open conversation around these issues. Whether that's more successful or not is a whole other debate, but they're able to engage around conversations about race. But unfortunately in Australia, historically, we haven't been able to do that. So I went into this meeting and dropped the R word, and it was very well received, I have to say. Again, as a result of many, many years of work by people before me. But that's a part of the work that AIDA works in and advocates for, is to not only have the conversation, but engage in the conversation, take people along that pathway. I mean, we all know the data, we all know the deficit basis that it produces for us. We all know the negative numbers, so I'm not going to go into that, except to say that it is recognised increasingly that there is a detrimental effect on individuals and on institutions themselves as a result of racism, and I'm very, very happy to say that these very conservative institutions are now willing, to a varying degree, to engage in this conversation. AIDA in this space, I launched the finding of AIDA's own racism and bullying survey last year, and as expected, the numbers were significantly worse than what has been found in mainstream surveys and strategies. But the information is out there, and AIDA as an organisation are willing and happy to engage in that conversation with organisations should they wish to have it. The other area of policy work for us is in the area of identification. So identification of Indigenous patients in healthcare. Now, it's been an issue for a long, long time. It's difficult to address. It was an issue when I was running the Logan Desert Health Service District down in the mid-2000s. The wider context is actually about cultural safety, not only for Indigenous patients, but for non-Indigenous, normally staff on the other side of the desk, feeling comfortable and empowered enough to ask the question. But it's an area that AIDA is engaged in at the moment. It's closely related, as I said, to cultural safety and the issues around that. And the workplace needs to be a culturally safe space, not only for the patients, but also the staff, Indigenous and non-Indigenous, to engage in that conversation. But once we normalise these principles, then it'll actually just become a part of mainstream culture. It'll become part of what we do, like name, date of birth, what's your address, are you Aboriginal or Torres Strait Islander, yes or no. But, you know, we are going along a path, and many of us, of course, are well aware of that and have been involved in the space for a long, long time. But we do engage in the difficult conversations at AIDA. And a part of the work that we've recently launched, and Greg Phillips and I actually launched this at our most recent conference in Perth this year, is the AIDA Cultural Safety Training Program. So this is a program that we've designed for cultural safety training to be delivered by Indigenous doctors to the colleges, mainly the colleges, and it's a full-day program. And it's been really well received. After it was released, we actually had a brochure stand and a sort of announced, officially declare it or whatever you do, the program open, and invited people to take a brochure. And honestly, it looked, senior people from colleges came over to that brochure stand, and it was like seagulls on a chip at the beach. It just was like nothing else. And they ran over, and they were all so excited about it, and they're engaged, and they're wanting to be engaged and involved. And so that's going to have a big impact on the system over the next 5 or 10 years. So the point I'm making is there's a lot of positive stuff happening in this space. And, I'm the eternal optimist. And I it's about hope. We're here because of hope. We're here because of hope. We're here because my own story, when my mum was living at the old army camps in what is now the inner city bypass down there at Gregory Terrace, with no running water and just these old shacks and no money. All they had was hope. But as a consequence of that hope, she got through that, and she married, and she had this wonderful family, and I'm a product of that hope, and a very, very proud product of that hope. And so I'm always hopeful for a brighter future, and always the eternal optimist. So we have little knocks along the way, like we all do, but it continually gets better for all of us as we go along, and I'd just like to acknowledge that. On that, though, my own journey with my own college has been a difficult journey, and I wouldn't wish that journey on anybody. But as a part of my progression as a consultant and as an Indigenous man, a number of months ago I felt the need to write an article, and it was a need that came from my gut, and I needed to write it just because. And the just because was partly because there needed to be a conversation in my own college around cultural safety, but there was also a sense that it was the right thing to do. Because if we don't lead from the front, if we don't continue to be warriors like Ken Wyatt mentioned earlier, if we don't continue to mirror the Pemulways and Windradines of the past, then we will stall. And the great irony is that the risks that we take in modern society are in context relatively less, and so we need to be brave. We're not going to be shot. Our kids aren't going to be removed. We have a roof over my head. I have food on my table. And so I wrote this article needing to engage in this space. And I want to share the article with you and then just give a summary of some of the response to that and I guess where I see the direction forwards from here. Not specifically for my college, but I just want to share a part of my own journey. And so it went into an optometry mag. It's just a rag that sits on waiting room desks, and it wasn't the Australian Medical Journal. It was a simple magazine. And I wrote the following, and it was titled "Closing the Gap from Both Sides." And I'll just read it. The dire state of Indigenous health is one of the most well-documented yet enduring features of the Australian eye care landscape. Indigenous Australians are twice as likely to have vision loss from cataract and experience more than 3 times the rate of vision loss from diabetic retinopathy, while more than 1/3 have never seen an eye care professional. We still haven't eliminated trachoma. There are countless reasons for this, and improvements can be made in a whole host of areas. However, an area that is rarely discussed is the relative lack of Indigenous eye care professionals comparative to the rest of the population, especially ophthalmologists. Out of more than 1,000 ophthalmologists in Australia, there is just one ophthalmologist, me. 3 months ago, there were none, ever. It's 2018. The Aboriginal and Torres Strait Islander population constitutes 3% of the Australian population. And in order to reach population parity of ophthalmologists in Australia, we need another 29 of me. The trouble is, the country's only training body, the Royal Australian New Zealand College of Ophthalmologists, have failed to recruit a single Aboriginal or Torres Strait Islander trainee to the vocational training program since I began in 2009. Which means in reality it will take at least another half a decade before there's even a chance of adding another to the tally. Why is this? There remains a lack of knowledge within the medical system of what it is to be Aboriginal. Institutionalised racism is endemic, and the system remains culturally unsafe. My own experience of blatant racism, degradation, training delays, bullying, harassment, and racial vilification are unfortunately considered an unremarkable experience amongst my Indigenous medical brethren. To many of us, racially motivated workplace violence is the norm. Institutionalised racism, unconscious bias, and cultural insensitivity might sound like buzzwords people kick around, but they are real and their impact is real. There were uncountable instances where I experienced direct and unashamed racism during my training. Some of those approaches were so bold as to be committed in writing. Without naming individuals, those responsible were my superiors, who in most cases had the ability to directly influence the progression or failure through the training program. They held absolute power over my career. These were individuals of high status and wealth, held in high regard by society, and whose behaviour was expected to be beyond reproach. The reality is that the college training system in Australia is structured such that a trainee is too often disempowered and cannot exercise the right of reply or defend themselves against malicious behaviour. To run against a senior colleague or question the college would mean running the risk of punitive action. As an Aboriginal or Torres Strait Islander doctor, you are even more powerless than your peers, coming from a background of genocide, poverty, and dispossession. I simply could not argue against the processes or abuse to which I was subjected. It's not okay, and it shouldn't be this way. Ignorance is the bedfellow of racism, and to combat it, we need to invest in continued education focused on Indigenous cultural sensitivity. It can't just be restricted to university either, as Aboriginal 101. What is required is cultural competency and a commitment to lifelong learning, just as medical doctors do with their clinical training. Rather than going round and round like a vinyl record the learning must be built on itself like a spiral, moving ever upwards and becoming increasingly sophisticated. We undertake continuing medical education to maintain and improve our clinical skills, but we should also be undertaking continuing medical education to ensure our social abilities are not only at the requisite level, but are improved over time, just as our scientific knowledge is. The ability to listen, express compassion, and empathise are qualities we should all have as doctors, and every bit as important as being technically able. In an increasingly multicultural society, the skills we learn through Indigenous cross-cultural competence are universally transferable and desirable. Unfortunately, at the moment, ignorance of cultural competency is a self-fulfilling prophecy. Many people aren't exposed adequately to Indigenous peoples and culture, and therefore are unaware of their own ignorance regarding cultural sensitivity. Openly racist individuals are not challenged. Key to the solution is training adequate numbers of Aboriginal and Torres Strait Islander health professionals across all areas in an environment of genuine respect and partnership, and addressing entrenched institutionalised racism, improving cultural competencies amongst health practitioners, and reforming the college system to be more transparent and responsive to change. All Australians gain from a better system. So that was the piece I issued, and I guess I wanted to read it today because the response to that has been overwhelming. And to bring things back to the topic of this meeting, it is that we need to move beyond the front line, because in 2018, the response to that shouldn't have been negatively overwhelming. There shouldn't have been meetings in ophthalmology departments in the public hospitals here in South East Queensland, on Yagara country, my country, discussing me and what an appalling document that was. There shouldn't have been the response in the same magazine yesterday from the CEO of the organisation criticising me without having had picked up the phone to discuss it with me. And I thought to myself, and I wanted to read it today because it has been a difficult process going through it, but I thought, well, you know, if these are the challenges that I'm having as the president of the Australian Indigenous Doctors Association and as a consultant ophthalmologist, then how much more difficult is it for our brethren and our young, whether they be in Cherbourg or Doomadgee or Wiluna or Karratha, and how significant the challenges are in getting those people over the line. But as I said earlier, it's about a partnership, it's about bringing people along, and I look forwards to engaging the CEO of my own college, and I look forwards to engaging all the colleges and taking them along this pathway of cultural learning and cultural sensitivity, because fundamentally the issues that apply to cultural safety are universally applicable because it's about humanity, and it's how we do things as blackfellas. And it's a lesson that the wider medical system and context, not only in medicine itself, but across all the health professions, can learn from. So I'd like to thank you all for listening today. It's, as I said, it's been an enormous privilege to speak here and a very, very humbling experience to have people who I look up to and very, very senior people amongst me, and to be able to address this forum. But thank you very much for having me and listening, and yeah, all the best. Thank you.
I just want to, I'm sure on behalf of all of us here, thanks, Chris, for your boldness. And hopefully it won't be too much longer that we don't have to rely on individual blackfellas' boldness to change the system, that we can, in moving beyond the front line, actually build an army. And I guess that's today the conversation we're trying to have, is how do we create the army that stands with our brothers who are standing up as the lone blackfella in these spaces still today.